Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for November 20th, 2024. Thank you for joining us today. And thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn series. Our presenters today are Drs. Laura Schmitt and Elizabeth Wellsandt. For our first presenter, Laura is a professor of physical therapy and assistant director of clinical and translational research in the School of Health and Rehabilitation Sciences at Ohio State University. Her research focuses on understanding neuromuscular control of the knee as related to optimizing rehabilitation outcomes following knee injury or pathology, minimizing disability after knee injury or pathology, and understanding the development and progression or joint degradation following knee injury or pathology. She has over 80 publications in clinical and biomedical outcomes after ACL reconstruction and OA. Her research has been supported by the Arthritis Foundation, NIH, American Orthopaedic Society for Sports Medicine, American Academy of Sports Physical Therapy, and the NFL Charities Medical Research Grants. Laura has served as the president of the Academy of Physical Therapy Research and chair of the Scientific Review Committee of the Foundation for Physical Therapy Research. She currently serves on the Secondary Prevention Task Force for the OAAA Action Alliance and also a member of the Research Committee of the American Academy of Sports Physical Therapy. And for our second presenter today, because one isn't enough, Liz is a board-certified orthopedic physical therapist and associate professor in the physical therapy program at the University of Nebraska Medical Center. There, she directs the Clinical Movement Analysis Lab, where her research team studies how physical activity and movement patterns of the knee contribute to early knee OA and other outcomes after ACL injury. Her research has been funded by the Arthritis Foundation, NIH, Foundation for Physical Therapy Research, and Rheumatology Research Foundation. Liz completed her PhD in biomechanics and movement science from the University of Delaware, and prior to that, she received her Doctor of Physical Therapy from the University of Nebraska Medical Center. We're delighted that Laura and Liz could join us today for their presentation titled, "We Understand the Risk of PTOA After ACLR to Patients." Laura and Liz, welcome. I'll let you take it from here.
Good afternoon or good morning, depending on where you are. Thank you very much for that wonderful introduction, Nick. I really appreciate it. This is Laura Schmitt. Both Liz and I are very happy to be here, not only as clinician scientists who work with individuals with ACLR and PTOA, but also as members of the OAAA Secondary Prevention Task Group. So we're excited to have some good conversation here about this topic. There'll be, I don't know if you've done these lunch and learns before, but if you're a regular, some of this might feel a little bit different. We're really hoping to engage the audience and have some discussions. So you will maybe momentarily see a poll come up. We just kind of want to get to know who you are a little bit better, and that can help gauge our discussion. So let's go ahead and get started here. Okay. So this is me. I have financial relationship with Ohio State University, where my salary is supported in part by grant funding, and I have no conflicts of interest related to this presentation. In consideration of OA as both a disease marked by structural and pathological joint changes, and as an illness being the lived experience of the patient, and often characterized by knee symptoms, functional limitations, and reduced quality of life, literature indicates that we see markers of both of these components within a few years of ACL reconstruction. And these problems, which are apparent early, both from quantitative MRI and also from patient-reported functional measures, this creates a need for secondary prevention. And that's why we're all here talking about folks with ACLR and at risk for PTOA. And the goal of secondary prevention is to identify an illness or disease at its earliest stages, and really to start treatments to slow or halt that progression towards long-term problems. And when we think about secondary prevention of PTOA after ACL reconstruction, our goal is really to promote joint health and well-being, and particularly within this time frame that you see at the bottom there called the lost decades of care. So if we have a younger individual that has an ACL injury more on the left side, it can be, any number of years before they re-engage with the medical system. And oftentimes by that time, they may already have structural knee OA and an OA diagnosis, which then sets them up for an early TKA. So really the point of secondary prevention is to start to identify the illness or the disease at its earliest stages, and then start to implement treatments that prevent this lost decades of care. The challenges with this are that there is a lack of high quality evidence to inform clinical practice within this space. And this is particularly evident. This is the National Public Health Agenda for Osteoarthritis that was updated in 2020. And this agenda could not address secondary prevention due to the lack of high quality evidence. So this really opens up an opportunity for consensus statements and consensus groups to fill this void. Consensus groups can fill a unique role in these emerging types fields with lack of evidence to help inform clinical practice. Consensus statements are generally based on both expert opinion, clinician experience, and available evidence. With this in mind, the OAA created the Secondary Prevention Task Group. I should say formed the Secondary Prevention Task Group. The goal of this group was to provide clinicians with secondary prevention recommendations that were meant to reduce the risk or delay of the onset of symptomatic OA after ACL injury, and to prevent OA-related disability and improve patient quality of life after ACL injury. So really, the goal of our task force was to provide insight based on both available evidence and expertise of the group members into areas that needed additional research and clinical recommendations. Our task group, which was comprised of about 29 members, we had groups across interdisciplinary professions and across professional organizations, came up with 16 recommendations in this area. And you see our infographic on the left-hand side. And our recommendations could be grouped into kind of these four recommendations: those that optimize education, which we'll come back to here momentarily, those that facilitate recovery and well-being, those that promote team-based care and continuity, and those that promote assessment and monitoring. If you are interested in these resources, there were 2 publications that came from our consensus statement. You can find them by using this QR code that's there on the right, or by looking at the OAA website. So if you're interested in the evidence review and our list of the full list of and discussion of the recommendations, you can find them here. At the same time as our secondary prevention group was working towards consensus statements, there were other things happening within the profession as well. And you may be familiar with the OPTI-knee consensus. Again, this was another international group that was seeking to provide a consensus on the recommendations for rehabilitation to prevent osteoarthritis after traumatic knee injury. As well as kind of in the middle of your screen there, you see this is work by Jackie Whitaker and co-authors that identified a risk profiles for sports-related post-traumatic knee osteoarthritis. And I want to go into these because even though at the same time point, we have 3 things kind of happening within the space, consensus items happening within this space, interestingly, all with different processes and different group members, came to some very similar conclusions and recommendations. So if we look here, sorry, I have a slight delay. If we look here first at the risk profile for sports-related post-traumatic knee OA, I want to draw your attention to this box here in the middle, particularly about inaccurate beliefs or unrealistic expectations. And this is on the part of the individual, some disregard on the impact of their injury on future sport ability and health. And related to this profile, the OAA Action Alliance consensus statement identified a series of recommendations to optimize education for both the patient, their caretakers, and the provider. And so our recommendations were to promote long-term joint health through education by providing accessible resources and tools for patients and caregivers, to promote understanding of risk of developing OA and ways to mitigate it, and to provide educational opportunities to the healthcare professionals on how to best educate patients about OA and OA prevention. This is a very similar recommendation that the OAA, the OptiNeek, oh, sorry, here we go. To promote I want to focus here a little bit on promoting the understanding of risk of developing OA and ways to mitigate that risk. And this is a very similar recommendation that the OptiNeek group found. And if you look at the bottom of your slide there, there's some text in there. You can visit the website up in the upper left-hand corner that has their full consensus statement and the recommendations. But as part of their publications, they have some recommendations on how to apply the OptiNeek clinical recommendations. So what can be done to help reduce the risk of PTOA? And their first bullet there is to collaborate with the patient or the individual to meet the informational needs for knee joint health and education, to guide them through self-management of symptoms, and to talk about how to avoid or address risk factors. And they identify some specific risk factors: weight gain, inactivity, and weakness. And they also recommend starting these efforts as close to the time of knee injury as possible and continuing across the lifespan. And I want to draw your attention to one of these factors, inactivity. And I wanted to take just a couple of minutes to talk a little bit more about declines in physical activity, given that it is this modifiable risk factor, and what we see after ACL reconstruction. So declines in physical activity are apparent as early as 2 years after reconstruction, where individuals with reconstruction spend less time in moderate to vigorous activity and are over 2 times less likely to meet physical activity recommendations, even if they have successfully returned to sport. And we know that physical activity and exercise therapy is associated with a whole host of positive outcomes, but specifically related to OA and its impact on effectively preventing or mitigating risk for many chronic conditions. So as part of our recent work, we wanted to do a study to understand more of the patient experience with the physical activity after ACL reconstruction. So we recently published this in IJSPT. It's a qualitative study of factors of perceived to influence physical activity among young athletes after ACL reconstruction. Our lead author was Dr. Christy Zawalski. This is part of her dissertation work. And our question that we were wanting to answer is, what are the lived experiences and perceptions of factors that facilitate or hinder physical activity among young athletes following ACLR? We had 10 participants, and you saw their age, kind of their other demographic information there. And we really organized, this was a qualitative study, so we really organized our themes across the socio-ecological framework, across different levels that impact health. So intrapersonal, interpersonal, organizational, community, and policy. And I'm not going to go into detail here, but I just want to highlight a few of the major themes and some of the quotes that I'll pull out that kind of exemplify the patient experience. And I particularly want to focus on this education piece. So one of the themes that we noted was gaps in knowledge. And you see at the top there that this individual really reported that they were never educated in how to weight train before. So you see part of the quote was, "I never really trained like that before. What is this? How are you going to do it, and why?" So this is an opportunity for us. The second quote talks about, they don't know the types of food or nutrition or exercises that they can do that can help them stay engaged. There was also a theme of motivation. So this was taking full responsibility for their physical activity, particularly if they had been involved in a sports team before. And they talk about that this is a transition that was challenging to them. The other major theme was, of course, about the impact of injury. And some of them reported that it took a while for their knee to feel completely normal again. Others felt that they always were feeling something, even if they were participating in a workout class, and wondering if it was just them that were feeling this. And others reported it to be more positive, like a catalyst for change in how they viewed and participated in physical activity. So the ACLR experience has the potential to significantly influence physical activity participation and perceptions, both positively and negatively. And we want to build on these experiences to inform and optimize patient education. And there was this is kind of my last part here, a recent publication in 2023 in BJSM. This are the patient partners of the OptiNeek consensus. And they have a very nice publication here that you see on the left. And I want to just read this quote and then we can continue. Even though it might be a hard conversation to have, we strongly believe that clinicians should be honest about the risk of re-injury or developing PTOA. Understanding the long-term implications might be a hard pill to swallow initially, but if we are not fully aware, then we do not have the opportunity to modify our own lifestyle and manage potential risks. Providing us with this knowledge empowers us to take control of our own health and well-being. So I think this is really set up for the next part here for Dr. Wellsandt. But before we do that, could we share the results of our poll? So it looks like we have a great representation here from many professions. So that's wonderful. And we have both those involved in research and patient care. A good portion of us work directly with patients, and we do have a few folks who have lived experience with ACL injury. So thank you for completing that, and I will now turn it over to Dr. Wellsandt.
Wonderful, thank you, Laura. Slides moving ahead, and we are going to have a second poll that might pop up here in a moment, just with a couple more questions to get to learn a little bit more about your experiences with education around PTOA after ACL injury. There it goes. Okay, perfect. So a quick slide on my disclosures. Again, nothing relevant to this presentation that needs to be discussed. So I want to begin with a paper that was published nearly 10 years ago by Fucht and his co-authors. They preoperatively surveyed 133 patients who were either going to undergo primary ACL reconstruction or were returning for a revision ACL reconstruction. And so they asked them after their first appointment with their orthopedic surgeon questions about what their expectations were after surgery. And in this first graph on the left, you can see that all patients expected to have a normal or nearly normal knee joint after having ACL reconstruction. Nearly all patients, 94% of patients, expected to be able to return to sport with either no restrictions or only slight restrictions. But interestingly, only 2% of patients expected to have a significant increase in their risk for knee osteoarthritis following their ACL injury and ACL reconstruction. And as Laura alluded to, this is in quite contrast to what we know about the high rates of both symptomatic and radiographic knee osteoarthritis within the first 10 to 15 years after ACL injury. Recently, we've asked some of these same questions in a cohort of 69 patients who were approximately a year and a half out from their ACL reconstruction. And so as we think about this, have we done any better over the last 10 years of having conversations with patients to set realistic expectations and understand what the actual outcomes are after these injuries? And so to begin with, they were asked to think back to when they were first injured and think about what their expectation was for their overall knee condition at a minimum of 1 year post-ACL reconstruction. And similar to the data from Fucht and colleagues, nearly all patients expected to have a normal or a nearly normal knee joint by that 1 year time point. Most patients expected to have no pain with any activities, although about a third of patients expected to have some remaining occasional pain during high impact sports. And this is quite consistent with what we know about pain levels at that 1 year time point. Maybe this has improved a little bit and expectations are a little bit more realistic. Only 60% of patients expected to be able to return to sport with no restrictions, while many thought that they might have slight restrictions. But if we look at this data, only 5% of patients during this recent survey expected a significantly increased risk of knee osteoarthritis. So this is quite similar to that 2% of patients who expected to have a significantly increased risk even 10 years ago. So this indicates that maybe we haven't made quite the strides. We certainly understand a lot more about knee osteoarthritis, but we might not have made the same strides in terms of our education and conversations with patients. We also asked patients some questions about their overall knowledge regarding outcomes and aspects of their ACL injury. And the first questions really were based on things that kind of occurred in that first year after ACL reconstruction. And so you can see that top one, most patients agreed that strength training should be part of their exercise program. They had an understanding of what would be required of them before they were cleared to return to sport. And most people agreed that their surgeon recommended that they undergo formal assessment by a physical therapist before returning to sport. This is a little bit different from their knowledge regarding long-term joint health. So we asked them an additional series of questions about long-term joint health. And that top one, we can see that still nearly 50% of patients did not think that ACL injury would increase their risk of knee osteoarthritis. A little bit of a different and unique question. We asked them if they were to develop knee osteoarthritis, would this be a major health concern for them? Again, the green bars are agreeing, the blue bars are disagreeing. So you can see over 50% of patients did not identify knee osteoarthritis as a major health concern. And so considering that many of these individuals are young individuals, we may need to do a better job of really having conversations with them about the burden that knee osteoarthritis can pose on an individual over the course of their lifetime. Again, many patients, nearly half, did not associate quadricep strength with the risk of developing knee osteoarthritis. And maybe a little bit better here, but still nearly a third of people did not associate being overweight with a higher risk of developing knee osteoarthritis. The final set of questions that I want to share with you is that we also asked patients, where did you get some of this information from? Where did you learn about these different things? And so you can see here when they, in terms of their treatment options, like whether to have surgery or not, as expected, a lot of this information came from their surgeon. Physical therapists also had these conversations, but you can see that friends and family, the internet, other physicians also provided some of this information to these patients. In terms of the importance of rehabilitation exercises, again, as expected, a lot of this came from the physical therapist, but also the surgeon and other people involved in their care. With return to sport, again, a high percentage of people receive this information from their medical team. But when we get to where they received information about their future osteoarthritis risk, based on this data, I would argue that it looks like surgeons and physicians are doing a little bit better job of this than rehabilitation specialists in terms of having these conversations, these difficult conversations with patients. But also the top there, you can see that nearly 20% of patients did not receive any additional information on their risk of osteoarthritis. So what current patient resources are out there? There are some really, really nice resources regarding ACL injury that we can share with patients. Gleedhill and colleagues published a few years ago in BJSM a couple of different infographics, and the first one really focused on that treatment decision and the need for a shared decision-making process of whether to have surgery or not. And the second one really focused on that year after surgery and what rehabilitation would look like and what return to sport would look like. And it did include some information on secondary injury risk reduction. But what I would argue is missing from this is this conversation about the risk of knee osteoarthritis and strategies to promote long-term joint health after these injuries. And so our secondary prevention task force has identified kind of this gap. And so we've worked to develop a REDCap survey to better understand the experiences and preferences of patients and parents of how they receive information about ACL injury, in particular regarding long-term knee joint health. And so we've developed this survey and we just launched it in the last few weeks. And the goal is to use this information so that we can start to develop new educational resources, both for parents and their parents and guardians. So we are targeting people that have had an ACL injury, or if an individual's child has had an ACL injury within the past 5 years. And I've included the link here. Certainly if you know of anyone that might like to participate in this work, we invite anybody to participate that has had that injury in the past 5 years, or a parent or guardian. And we'll be sharing this information in a follow-up email as well to get you this information. So to kind of loop back and wrap everything up, this is one of those recommendations that Laura presented from our consensus statement. And I think it's important to recognize that not only is it critical that we talk about the risk for developing osteoarthritis with patients after ACL injury, but we really also need to have conversations with them and provide them strategies and ways to mitigate this risk. And these can include things like symptom management, ways to maintain a healthy body weight and the role of nutrition in that, obtaining regular physical activity, maintaining lower extremity muscle strength, and avoiding additional injuries that would further increase the risk of developing the osteoarthritis. And with a final slide here, I'll also come back to that patient voice with some of the patient partners from the Optimini consensus group. And I think, especially in that first year when patients are really involved in rehabilitation, it's easy to kind of get in the weeds and really have this focus on return to sport. But it's important that we step back and look at the big picture and really think about long-term knee joint health at a time when we're really engaged with patients. And it's likely that a blanket approach to this won't be effective. We really need to think about how we can individualize the education and the long-term joint health strategies for patients so that we provide them with ways that they can manage their knee joint health and adhere to exercise and diet recommendations over the course of their lifetime. So with that, I think we're ready to open it to any discussion and questions, and maybe we can share the results of that second poll. So in looking at this real quick, it looks like, about 2/3 of us, or I guess the people that do regularly engage with people after ACL injury do include conversations about long-term joint health. That's probably not too surprising given the people that are interested in this are likely on the call. And so that's really, really nice to see. The next question was about what types of resources and information are provided to patients, and it's a nice split of a lot of different things regarding, thinking about pamphlets and printed materials, website resources, and just having conversations with patients around that. So, yeah, this is really helpful to see, and we're really hoping to gain even more information through that survey to better understand how clinicians are interacting with patients regarding some of these difficult conversations. Nick, do we have any questions?
That was wonderful. Thank you so much, Laura and Liz, for that fantastic presentation. I loved it. It was no problem. It was perfect. We have time for a couple questions. So as a reminder, you can type any questions you have in the chat box and read them aloud. And also in a few minutes, you'll see a poll pop up on the screen with some survey questions. If you can answer those before you leave, it would be greatly appreciated. I'm geeking out. I can't help it. I know I saw the one statistic that Liz did about only 2% expected to experience an increased risk in developing OA later in life. And it just, my mind's blown from that. And, being educators that we are, do you think that the education resources should be consistent between the individuals with the ACL injury and their parents and their caregivers, or should they differ? Should it be resources created specifically targeting those with the injury and resources specifically targeting the parent and the caregiver?
Thanks, Nick, for that question. I can start us off, and then Liz, please chime in, or anybody, please chime in, even through the chat there. I think, as this was alluded to in some of the work that Liz showed there, we really do need to have some targeted resources available. ACL injury affects such a wide range of folks, from, pediatric patients through adolescents, through young adults, and into adulthood. And then also, PTOA affects at different, because of that, PTOA can affect at different phases of life as well. So I think having some targeted education materials is a really helpful thing. Those that target not just by different age ranges, which might vary with the risk factors, but also, as you said, Nick, some targeted towards the patients, clients, individuals themselves, as well as those to their caregivers or other loved ones who may be involved in their care and health promotion.
All right, thank you. I really appreciate that. And does anyone else have any other questions? Checking the chat box, see if there's anyone else put anything in there. Well, thank you, everyone. That concludes today's presentation. Please join us next month on December 11th when our Lunch and Learn presenter will be Dr. Lauren King, who will discuss the opportunities and challenges of early knee OA. Have a great day.